This video will demonstrate the microsurgical resection of a T12 intramedullary spinal arteriovenous malformation. The patient was in her early 30s. She presented with sudden onset back pain a year ago. This was managed conservatively until she developed bilateral lower extremity numbness and paraparesis. She began using a walker 3 months ago. An arteriovenous malformation was finally identified on further imaging workup. Here are selected angiographic views showing a well-circumscribed nidus at the T12 level fed from arteries on the left side. There was also some supply from the right T9, which you can see in the center image descending downward to fill the AVM from the right. The AVM is shown in the left image pre-embolization and on the right side post-embolization, indicating a good filling of the AVM with glue. The patient was taken to the operating room and positioned supine on a Jackson table. We performed a T11 to L1 laminectomy through this midline incision. Surgical strategy includes the preoperative localizer placed during the embolization procedure. This facilitated the identification of the appropriate levels. A T11 to L1 laminectomy was performed. First, a pathway was cleared through surface veins to the Peel surface of the dorsal spinal cord. Next, the feeding arteries were identified and occluded on the surface. This allowed for a midline myelotomy with subsequent definition of the intramedullary separation plane between the AVM and the normal spinal cord tissue. The AVM was mobilized into the center of the cord as the dissection proceeded, and indocyanine green videoangiography was used to identify residual AV shunting throughout the case. Here is an overview of the exposure. You can see this complex of veins on this dorsal surface of the spinal cord. It's difficult to see where the AVM is with all of the vascularity here, but as we investigate the vessels here, you can see this large embolized feeding artery here, which is transected and followed down to the Peel surface. The AVM then gets lifted and rolled, and by so doing, you can perform a midline myelotomy. The pia here is being incised in the midline so as to get along the border of the AVM between the AVM itself and the cord parenchyma. You can see these feeding arteries come into view. They are cauterized and divided as they are encountered, and you can see some significant reduction in flow in the AVM. Here is indocyanine green dye study, which shows persistent shunting in the dilated veins on the dorsal surface, but some significant reduction as well in the supply. Here, the vein that was quiet is cauterized and divided. This allows the upper dissection plane to be developed. You can see the myelotomy here is being extended superiorly. You can see the AVM nidus itself is starting to darken. This allows us to be more aggressive with cautery as we shrink the nidus and pull it into the center of the surgical corridor. This helps to develop that separation plane between parenchyma and the AVM itself. Continuing that theme, you can see how cautery is very useful to shrink the nidus and help to mobilize the AVM. That purplish color tells us that we've eliminated most of the supply that was reaching the nidus from the back, and all that remains is the anterior supply from the spinal artery. As we get down to the later stages of the resection, we're almost to the front of the spinal cord. You can see that the AVM is being teased away from the cord itself, and I'm actually getting into the nidus. At this stage, it's not as critical to preserve that separation plane between the AVM and the spinal cord, but actually to get into the AVM itself and pull it away from the remaining cord tissue. This is something that we would never do with a brain AVM, but in the spinal cord that's been dearterialized, we can be more aggressive in working across these final planes by working through the AVM. Here's a varix that's being pulled away from the adjacent spinal cord tissue. And once again, these final feeders on the deep side coming up from the anterior spinal artery are identified cauterized and divided. Now you can see that the AVM is almost freed. The draining vein, the venous pedicle here, is cauterized inferiorly and cut. And with that cut, you can see that the AVM is freed and removed. Here I'm carefully inspecting the nidus that's along the anterior spinal artery, taking great care to make sure that no residual nidus is left there at the depths of that cavity. We can now do our final indocyanine green angiogram, and you can see that there's good perfusion in vessels to the cord, but no arteriovenous shunting, and those veins on the surface are quiet. Here is our final overview shot showing the resection bed, and here's the dural closure. These illustrations nicely demonstrate the anatomy of the type 4 intramedullary concentric spinal AVM. The AVM nidus occupies the central portion of the spinal cord and displaces the tracts to the periphery. The upper inset to the right shows the relationship of the AVM to the surrounding horns of the spinal cord. These AVMs have blood supply from both anterior spinal artery and posterior spinal arteries. The AVM typically requires dissection into the cord through a midline or perinatal trajectory. The illustration at the bottom right demonstrates how the midline myelotomy takes the dissection around the margins of the AVM through the spinal cord tissue all the way to the front, where anterior spinal artery feeders can be reached on the ventral surface. Interestingly, after embolization, her lower extremity strength improved. This suggests that some of her deficit on presentation was due to arteriovenous shunting and venous hypertension with compromise of cord perfusion. Postoperatively, she was slightly weaker, but this weakness was transient and subsequently improved above her baseline. Her numbness also continues to improve above her presentation status. She was discharged home on postoperative day 4. Here's her postoperative spinal angiogram, which shows no residual AVM. In conclusion, concentric intramedullary type 4 spinal AVMs are supplied by anterior spinal artery and posterior spinal artery. The central location of the nidus is located within the cord, displacing gray matter and tracts to the periphery. Laminectomy exposes these lesions, and the posterior cord is covered with dilated draining veins that resemble exophytic nidus, where the posterior nidus and PSA feeders are identified. Extramedullary dissection deepens through the PIA to transition to intramedullary dissection, where the AVM nidus and the ventral feeders from the ASA can be occluded. Thank you.